Hi, it's Dr. Parikh, and we're talking about Module 6, Health. Let's see. So we'll talk about disparities in women's health, especially thinking about different groups of women. Race, we know a lot. Thinking about between men and women, and also thinking about trans women's health. We'll also talk some about maternal health, so an experience that typically men would not experience. And also thinking about health in the US compared to other countries, because our course mostly focuses on gender issues within the US. And then we'll also think a little bit about mental health, especially thinking kind of historically how we've gotten to where we are with mental health as a country today. The first lecture I find really interesting, and I also personally struggle with as someone who exists within US culture. So PMS could be considered a culture-bound syndrome. So it's something that not all cultures experience, and it's something that's relatively new within American culture. And it really pushes the question of what is illness, how do we define illness, and how culture shapes our experience of the world, including what we experience as emotions and difficulty. So one thing that's just kind of an interesting thing to consider is a change in how much time adult women spend pregnant or lactating. So to be honest, adult women on average have not spent as many months of their lives menstruating as we do today, because if you're pregnant a whole bunch and then breastfeeding because there is no formula in a friendly pharmacy down the street, you just don't experience very many periods typically. So it's interesting just to consider how, as we have taken more control of managing fertility and had more options beyond lactating, it affects menstruation. Also, you could think of, the introduction of medications that can treat this disorder. So sometimes birth control can be used to affect menstruation symptoms, and you could also, or to eliminate some periods altogether. And there's also some treatment of symptoms using like depression medications. And the chapter also talked about some interesting sort of expectations of consistency. And we know from my understanding, one of the biggest differences between men's bodies and women's bodies is that women's bodies experience fluctuations in hormones. And that's why women experience, so I think 3 out of 4 migraine sufferers are women, and many women experience migraines linked to their hormone cycles. And it's kind of the irony of women being labeled as unhinged or angry, which is really ironic because the vast majority of violence is committed by men. And there's also just, so we think historically, we can look back like ancient Greek, and they would have these like bacchanalia, I may be saying that wrong, but they would have these kind of wild parties or celebrations where women would become essentially, again, really rough understanding here, but sort of become possessed. And it was this culturally sanctioned, just letting loose of all of the restraints that are constantly put on women. And so PMS may be viewed as women's only culturally sanctioned opportunity to express anger. But we dismiss it by saying you're not angry because the situation is unjust. You're angry because your body is betraying you in a way that only women's bodies can betray them. So it's really interesting to me to read about the cultural variation in experiences, and also to think of PMS as partially a backlash against feminism and women's empowerment. And we've talked several times about how often when you look historically, periods where women make great strides, or really any cultural group that doesn't have the majority of the power makes great strides, there's often a kind of a blowback where you get set, you move forward in several areas and then you're moved backward in kind of related but not exactly the same areas. And you always have to think, I mentioned medicalization already, who benefits when we medicalize women's experiences? There are people who are literally financially invested in getting you to buy products to solve problems. whether it's buying special Midol instead of ibuprofen if you have pain near your period, whether it's selling you lots and lots of products to help you manage your period, or again, birth control, antidepressants. A lot of things can be used to prescribe things that other cultures, and what really, I don't think I emphasized it enough, in the US, there's little tolerance for fluctuation and for cyclical changes. There's this sense that everything has to be consistent and controlled constantly. Even things like, I think to some extent, that people aren't supposed to age, or that pregnant women are supposed to lose the baby weight immediately. And so I think that other cultures may experience some of the same things, but may see it as just like that's just what happens then, instead of seeing it as a real problem. I don't know. And this one genuinely is tough for me. I frequently perceive that I am more emotional in the days before starting my menstrual cycle. I also, it's tough. I also experience migraines, and those are often, the worst ones are often linked to hormone changes related to a menstrual cycle. So in some ways, I've drank the Kool-Aid on this one, meaning that I buy in to the idea of PMS, but I also see everything they're saying, and this chapter really makes me wonder if I am labeling an experience that doesn't really exist. Because often I may, it's often I realize that it's the beginning of my menstrual cycle, and I say, oh, maybe that's why I've been so emotional the last couple days. And it's really hard to say. When you ask people to look back, they often will say, yes, I'm more emotional before my period starts. But when you actually gather data going forward, you will get a different answer usually. Usually you'll see people, if you just look at emotion journals and other things, you can't typically, if PMS really existed as strongly as people talk about, you would think that you could clearly pick out when anger and frustration and sadness pick up quite a bit. But when you're looking forward, when you're not looking backward, when you don't know that it's right before your menstrual cycle starts, observers can't tell the difference. So on the one hand, I'm so enmeshed in the society and this way of thinking that it's hard for me to not interpret my experiences in this way. But on the other hand, I trust the process of research. So this one's tough for me. The next one talks about Black women's health in the US. So we get that word intersectional again, and we think about social structural perspectives. So thinking about how society and the structure of society contributes to what is experienced by this group of people. So first they talk about the invisibility. I love this chapter. I hate the content. I hate that it exists, but I love the way that Boleg really illustrates what's happening. So first is the idea of the invisibility of intersectionality. And what I love is they talk about how collecting the data isn't enough. You have to actually do something with the data. So the researcher might gather personal data on, age, race, gender, sexual orientation or sexual identity on lots of different pieces. But often when we report data out, we only look at one group at a time. And so the person might report on differences between men and women and differences with Black people versus non-Black people, or people of color versus Caucasians or white people. But it's much more rare to look at subgroups like Black women or lesbian Black women or trans Black women. And so it's very difficult to actually know the data and know the differences, because if you just look at what's reported, often you don't see those subgroups. And so these differences, these disparate populations, these populations that are receiving a different standard of care or having a different set of outcomes may be hidden in the data. And of course, sometimes people don't ask. And it's tough because with research, you want to respect people's privacy, so you don't want to ask too many questions. You want to keep surveys short so that people don't drop out. And so you're always balancing the value of the data against the sort of personal nature of the data. So it's tough. I really like the way that she sets the stage with key terms. So talking about race, we often think of race as something that's sort of part of our biology, but there are sort of stereotypical markers of features and pieces. Like there's some ways that we differentiate race, but race is a socially constructed thing. And you can see people who live kind of, for example, when I look at people who live kind of in the border of South Asia and Northern and Eastern Asia, it seems like there's kind of this gray area where they have some features that look more traditionally South Asian and some features that look more traditionally East Asian. And so it's, even when we look at people, there's in-between blends. And our modern conception of race is really based on justifying slavery, explaining how it was appropriate to treat a group of people as less than people. And so to justify it, we used all the shiny science to show how the races are distinct and white people are superior. Clearly, lots and lots of flaws with that. Next is sexual identity, and you noticed me, I corrected myself once already. I said sexual orientation and then moved to sexual identity. And this, I like the term in particular, sexual identity, because it's pushing against the idea that sexual identity or gender is biologically rooted, that it's an essential feature of a person, and that it's a fixed trait. So because of this chapter in my own life, I'm trying to switch over to using the term sexual identity instead of sexual orientation, because sexual orientation in general feels kind of stigmatizing and dated to me. And I think that I agree with a lot of what she says about what's better about talking about someone's sexual identity. And then health inequities. So she really wants to emphasize it's not just a difference, it's an inequality. It's unjust and unnecessary. So these are, they're problems that we could address as a society if we chose to. She listed, so one issue is the difference in how much we talk about certain issues. So we've got breast cancer. So when we think of women's health, we often think breast cancer first because that's what's most prominently advertised. But it's actually heart disease is the greatest killer of women. But we think of heart disease as a men's issue, or when we think of women's health, we only think about things that affect uniquely women instead of thinking of women as, just whole beings. But even when we think about issues that are dangerous for women, they are significantly more dangerous for Black women. So I don't have as detailed notes here as I could. So breast cancer has potentially 39% greater mortality for Black women. So it's almost twice as deadly for Black women as it is for white women. I'm sorry. It's almost 50. My brain just froze. I'm sorry. But it's significantly more dangerous for Black women than for white women. And then the chapter goes on to talk about how when we try to address health inequities, we often focus on the symptoms rather than the causes. So we might say stress is contributing, so you need to work on your stress, rather than looking at the causes of that stress, such as inequalities. And she really, I love, as someone from a working class background, I really like the way that she talks about the privilege in the recommendations. So, for example, there's a recommendation of 3 fruits and 4 vegetables for 64 cents a day. And if that were true, it seems like, okay, so for $20-25, you could be eating healthy for $20-25 a month. But she talks about how these figures are I think it's almost 30 years old, and that they were probably unrealistic then. I forget the details, but it's just so mind-blowing that anyone would believe this, anyone who has ever visited a grocery store recently. And even at the time, I also really question a big part of healthy eating that's promoted is eating a diversity of food. And so I kind of wonder if they just picked the lowest couple fruits and vegetables and calculated based on that instead of thinking about getting they talk about eating from a rainbow of foods, and blue fruits tends to cost a little more than green and yellow fruits. Another issue is they talk about exercise, and there's lots of barriers that we all experience for exercise, and and she addresses the issue of saying, well, just, go for a walk outside. If you don't live in a safe neighborhood, that's tough. So again, the people who are most affected by this danger are the ones who have the most stress to start with and the least resources to deal with it. And I'll give you an example for me. So they also, I don't know if the author mentions it, but you have to have something to do with your children while you're doing this. So when I can walk outside with my child if I live in a safe neighborhood, but my child, there's more limits to how cold I can go out with my child. I can bundle myself up pretty strong, but I may not want to take my child out as cold. And if it's a little snowy, I need better space for my kid's stroller. And I need sidewalks. Might be able to walk along the side of a road safely. I'm much less likely to feel safe with a child in a stroller on the side of the road. And sometimes as a parent, when I make decisions, part of what I think of is how it would look if the worst happens. And so if I'm walking on the side of my road or in a dangerous neighborhood with my child in a stroller and we get attacked and something happens to my child or we get hit by a car, I really think that the narrative of society would be, why on earth would you have done that? You can't really, that was so foolish that you kind of got what was coming to you. Or how sad for your child that they had such an incompetent mother. On the other hand, so my spouse and I are in a situation where we're really struggling with exercise because we have a small child, we both work full time, and he's in daycare 5 days a week. And so when we want to get home, even if we want to go to a gym that's, $100 a month for both of us that provides childcare, first of all, they usually only provide childcare during certain hours of the day, so it has to be one of those hours. And it's just more time that our child is in care and not with us. And so if I'm already working 8-9 hours a day, plus travel time to get to and from my job, it's just not a lot of time left to be with my child. And even, when we get home, it's just a push to okay, let's get dinner on before he melts down. And then let's spend half an hour or so together before we have to start bath time and books and bed. And then when that's all done, it's 7:30, 8 o'clock. We at least have two parents living in the same household, so often one of us could go out while the other one stays home, but we are exhausted at that point. But we definitely can't both leave at the same time. And so we have this, there's this issue of access for, and again, I talk a lot about having a young child because that's the stage of life I'm in right now, so that's what's salient to me. And for us, we really agonized about what to do, and what we ended up doing is buying a Peloton. And if you do the payment plan, they purposely make it right about around $100 a month because I think that's what a lot of nicer gym memberships are. I think a really nice gym for one person or a nice YMCA for two people. And it's nice because it cuts out our travel time. We don't have to, even things like packing and unpacking bags and all of that can be really stressful. So going to the gym, and if you go with a child, you have to check the child into daycare, check the child out of daycare. Usually there's a 90-minute limit at the most. So if you're going to a class, you're trying to drop your child off, then change clothes, get to class, come out of class, shower, change clothes, and get back up, all within an hour and a half. So a workout can stretch quite a bit. So with the Peloton, it's a really high quality equipment. It's really high quality classes. It feels to me like going to a spin class. But I get to eliminate the travel time. I get to eliminate packing a bag. And we can go early in the morning, in the evening, we can sneak it in the afternoon. It's really helped us access exercise, which we've been really struggling with how to do lately. But at the same time, it's not only $100 a month, it's a commitment to $100 a month for quite some time. And so there may be families who can maybe get reduced rates for a gym, or can do it for now, but we're not sure. It's much different to make a commitment, and you have to pass a credit check to get that special financing. So there's a lot of pieces to consider, how having more resources, we also have the space to put it up in our house. And a bike isn't terribly large, but it's still a thing. And so when you think of having a home gym, there's a lot of privilege that goes in with having that. So yeah, they talk about dangers of being outdoors as women, barriers to activities for people with disabilities. So going out into the world can be difficult. I don't know if she talked about, when you can hop in your car and go wherever you want. It's very different from trying to get around by bus. Uber creates a middle ground, but you still have to have the money to pay for it. So yeah, there's a lot of advice that feels very unrealistic. Especially when you think about the amount of stress, the low wages, the amount of just hours needed to work to keep things together. I've said before that I really wish that there was an option to slow down just a little bit career-wise in early parenthood, but that's usually not available. The last thing that I really, really loved about this chapter was when she talked about asking the other question. So when you see one sort of discrimination or problem, look to see if there's another type. So where there's racism, ask, where's the patriarchy here? Where there's heterosexism, ask, where's the classism here? So always look for the other pieces of discrimination. And she talks a lot about, again, that sort of symptoms versus cause. Whew. Women and hysteria in the history. I think it's in the history of mental health. So this one is an odd little article. It's written by non-native English speakers, I think, or at least not, they seem very fluent, but there are a few things that are just not quite typically American phrases. So a few things stood out to me. I'm just going to run really quickly through. So early gendering of mental health, how quickly it became men versus women. Hubris in science, how when people have such huge, firm faith in their beliefs, it really puts them in danger of looking like an idiot later. So for example, looking for other possible causes for gender differences in mental health than just, hey, my uterus, it's just wandering all over the place in there. And then it talks about the shift to connecting both women and mental illness to sin. And the changing meaning of sex and abstinence. It's kind of like it means one thing here, and then it means the opposite later. So these things, it helps me see how socially constructed these beliefs are when I see how much they've changed over time and how different they've been in different cultures. I've used the word essentialism a few times. When we say something's essential, we say, or essentialism is the belief that like this is just the way it has to be, this is the way the world functions. And so when we see how this unfolds in other cultures, we get more and more challenges to the idea that this is just the essential features of this thing. We see this trend where anytime known causes get ruled out and we can't explain a thing, it just gets labeled either mental illness or supernatural. We see it, again, this kind of moral piece where it starts being associated with foul air, which is associated with big cities, and also laziness, which is very much still in effect, especially for people with ADHD or depression, where it really either hits the energy or the focus. There's a lot of messages about laziness, and I think those are often more strongly focused toward women, especially because with things like ADHD, we aren't very familiar with how women present with ADHD or autism. We think of male representations, and so female presentations are often just kind of labeled as being ditzy or lazy or some sort of moral shortcoming. Placebo effect is well alive. If you treat something and then you feel and you think it'll work, you typically do feel at least a little bit better. Victorian smelling salts. This is fascinating to me. that, because I knew about them, I thought it was just kind of meant to like make you more alert, perk you up, but in fact it's specifically to push your womb down where it's supposed to be, or so just shove that wandering womb right back where it goes. Or I forget if it was this age or a different time period where you could also, if you thought that the womb was going too low, there's another opening that you can expose the smelling salts to. So it was just bizarre to me, but this is something that many, many people in the culture truly believed because it's what the best scientists of the day were saying was true. Then mental illness starts becoming viewed as part of immaturity, and then manipulation, secondary advantage, and this idea of women as being sneaky and manipulative. For example, if you look at Bible stories, often the women are either angelically good or sneaky and manipulative. There's not a ton of complex women figures in the Bible. And so when we think of, but for me, when I look at women being portrayed as sneaky and manipulative, and honestly the same was said of slaves too, that they were sneaky, manipulative, lazy, immoral. And part of this is when you have no direct power, the only way to have any measure of control over your life is to use indirect power. And so, of course, you're going to become sneaky and manipulative if no one gives you power. When people feel like they can come up and directly say what they want and how they want to do things, they don't need to sneak around. It's funny how that works. So when we think of mental illness as manipulation, it's that secondary advantage, the idea that I'm getting something out of presenting myself as sick. Then it talks about cultural experiences of mental illness. So going back to that idea of PMS. So over time in US culture, we've seen hysteria go way down, but anxiety and depression come way up. And they present a few examples of 19th and 20th century treatments, but I'm always very cognizant that we have not somehow arrived at some magical perfect time. We're just in the middle of the timeline. We just can't see what comes next. And so I'm very curious how others in the future will describe and judge our mental health practices. And I just will close with this super depressing quote, 80 years in psychiatric hospital for a headache. How easy it was to get checked in and how hard it was to get released in any way. Right. Gender and women's mental health. We know that there are differences in rates that people report and experience things. So when we think about disorders in general, there are some that are pretty common: depression, alcohol dependence, antisocial personality disorder. Others are very rare. So schizophrenia, bipolar disorder, those are pretty rare. When we think about differences, it's important to think about women experience more violence. We have more just barriers and adversity in general in our social worlds. And also there's a lot of economic and social policies that make it more difficult for women to get the resources they need and that just create more oppression. We also know there's bias in treatment. So things like who's given medication, who's willing to even disclose different issues. We know that there's stigma, so particularly things like anxiety and depression, it's more acceptable for women to acknowledge that we're having it. And then also stereotyped presentations. We think of eating disorders the way that women present with them. We think of antisocial personality disorder the way men present with them. And then there's protective factors, especially for depression. Things that help with depression are things that women have less access to. So things like a sense of autonomy and control over our lives, the material resources to feel like we can make meaningful choices, and support of family, friends, and health providers. These are all the things that really do seem to help protect against depression. So it may prevent depression or reduce the severity. And they're important things to make sure that women have access to, that all people have access to. The next one looks at overall women's health compared to our peers. So the US is pretty much the worst. It's tough because somebody has to be the bottom. And so when you're looking at the group, if we're all pretty good, someone needs to be at the bottom. But we're also looking at the size and significance of the gaps. So it's not just that we're last, it's how far away are we from the others. And they didn't discuss the issue of variance. So how kind of, so if everybody else falls in this range, and we're falling way down below, that's more serious than if it's kind of, a wide range here, and then a wide range here, and then a wide range here. So just knowing the average doesn't help as much to know how different the different groups are. We look at particularly chronic conditions we struggle with. Emotional distress, 7% was the best, 34% was the worst. I will say Americans in general have a greater expectation of happiness than many other people. And so we may feel more disappointed because our goal is to always feel like we're at a 10, and most other people are maybe pretty happy feeling somewhere in a 6 or a 7. And so, of course, if everybody's feeling like they're at a 7, but we want to feel like a 10, then we're going to be less happy. So it's harder for me to interpret that, because it could be that we're genuinely experiencing more distress. It could also be that we interpret our distress as more distressing than other people. Maternal issues, more women die in childbirth in the US than in any similar country, and it's ridiculous. Also, they talk about issues with medical bills. Most of our peer countries don't have nearly the high medical costs that we do, and cost-related access. So it seems like having a regular doctor in place of care is really important. Again, the US had more trouble with that than most countries. They also looked at things like how the quality was rated, the quality of medical care, how many times we're using the ER, so more is typically bad. And they did, in this article, they did talk about some of the limitations. So that was nice that they acknowledged some of the ways that, throughout, they acknowledged ways that their data was not perfect. So racial and ethnic disparities. This is from our CDC. And they say most of these maternal pregnancy-related deaths are preventable. And so even not just compared to our peers, compared globally, we have really poor rates. And it's tough to pinpoint exactly why that is. We also see that it's race and education layered together. So for every one white woman with a college degree who dies of pregnancy-related issues, 5.2 Black women with a college degree die. So the death rates, even when we look at same levels of education, which is overall sort of a barometer or a metric for how well, for social class, for income. It's not a perfect measure, but it's an easy to gather one. So even when we look at the same education, Black women are dying 5 times the rate of white women. It's been stable for the last 10 years. And the issue is, when we don't want to acknowledge the possibility of racism existing in our healthcare system or in any system, we can't improve it. You cannot improve what you cannot acknowledge. So the first thing we have to do is acknowledge that it's happening, and then think about how we can create standards of care to better address issues. And also, again, just acknowledging the systemic bias. Part of it, I think, when we have a culture of finger pointing and calling people racist, that makes everyone want to freeze up and deny any racism. And when we are doing that, we really can't move forward. I think it's much better when we can acknowledge that we are all influenced by this system. Just like it's a silly example, but I talked a few minutes ago about how it's not the first time I'd heard that PMS has no evidence, and yet I still interpret my life with a sense that my emotions are different in the few days before I start my menstrual cycle. And I'm not sure what to do with that information, because it still feels very real to me, even though the science says that it's not there. And so that's a silly example of being willing to acknowledge a flaw, but I think it's an example of how it's important to acknowledge that this discrepancy exists, because I could easily just say, oh no, I don't believe in it, but then privately kind of be influenced by it, even if I don't realize. That's the other piece about racism. We don't realize that we're engaging in it often. It's not just people who are spreading white power movement information. It's also people who believe that they are egalitarian, that they want to treat everyone the same, we still fall into these traps, and we have to acknowledge them and work to correct them. And then Serena Williams just gives a firsthand account, and she is a very well-known, very famous, I'm sure very well-moneyed celebrity, and yet she had difficulty accessing the healthcare she needed after giving birth. This last one, I talked a little bit in the overview that I'm a little skeptical of their whole shtick. So first, I'm curious if I suspect that they wanted to get rejected from the Oscars because, again, I have a hard time seeing similar sorts of other medical issues getting approved based on the Oscars policies. But I think they are addressing a bigger issue of what is seen as too graphic and acceptable. I do wonder if it's just women's health or if it's all health realities. If we don't want to see what it's like for people with chronic conditions or with other health issues. But part of it is, I think part of what makes childbirth different is that it is a normative life experience. Not that everyone has to experience it to be fully human. Not that every woman has to want to experience it. But it is a very normative, typical experience. And I think that I wonder if the things that we hush about and are not good to talk about in polite society, I wonder how much of that tends to be things that happen to women. And I suspect that it's a lot of them. So Transgender Health, looking at... I wonder if I left one out. No, I do have it up there. Okay. So Transgender Health, this is an article that kind of talks about basic information. So in general, this course, and it's tricky because I'm trying to focus on women. I'm trying to not get distracted by talking about men's experiences because they do have more privilege and power in general. But then there's this ambiguous, what about trans, non-binary, and gender non-conforming populations? And so I try to talk about all of those, including men, at least some in this course. And so here's a reading that talks about specifically health-related issues. It also talks some about violence, discrimination, sexual and reproductive health. So one issue is that trans men can have periods, and that can be really difficult to figure out how to deal with. And as a cisgender person, so someone whose gender assigned at birth matches my gender identity, it's really hard for me to imagine how just icky it must feel to have these physical reminders of a body that doesn't match how you identify. And again, it's not all binary, I fully identify as a man or I fully identify as a woman, but there are some people who do fully identify as the gender other than their biological assigned at birth gender. And I just feel a lot for how, for one, it's kind of a regular reminder that your biology doesn't match your identity. And it can feel kind of icky and like you have this loss of control over your body. The article also talks about and also with periods, the other piece is, it just is so, everything around periods is very girly and feminine and flowery. And I believe Always, menstrual pads specifically had a campaign where they they had previously a female symbol on their products, and they took it off to try to be more inclusive of various gender identities that need menstrual pads. And then there's also, there's other reasons that people may need to wear a pad in their underwear, like hemorrhoids or other things that might cause problems. And then they talk about substance abuse. This page doesn't discuss mental health, which is disappointing. We know that discrimination and the constant stress that can come with it affects mental health. And trans people and other sort of gender non-conforming individuals really do face a lot of potential for discrimination. There's not a lot of legal protections for places like your job, your place to live. There's just a lot of potential for abuse within the system. There's a lot of risk for violence. And so that all very much, and there may not be family support. So this idea of health, I was just disappointed that they didn't address mental health. This next video there, it talks about medicine can have a dangerous side for women. So they talk about the way that we approach medicine these days is meant to, the intention was to protect vulnerable populations. The Tuskegee syphilis study is the example of informed consent and of populations that are viewed as less than people. And also pregnant women, there are lots of medications that have been found to negatively affect fetuses, even if it doesn't affect the woman at all. And the issue is, it often takes quite, many months or even some years to find, depending on when the issue emerges, to find that there's damage to the fetus. But it's important to balance the dangers of including women with the dangers of leaving women out. So thalidomide is the leave them out argument because it's a motion sickness drug or nausea medication that was really, really helpful to women. It did relieve their morning sickness, which, side note, morning sickness is really just kind of all day long sickness. It just never really goes away. Everything has a smell. It's not terribly fun. And so it would help with morning sickness, but later when children were born, there was this high number born missing limbs or having other sorts of defects. On the other hand, we've got Ambien, where women, and the doctor here kind of discusses, I wonder how many of the people I treated in the ER were because of Ambien. It took a very long time to gather enough data and recognize that a dosage that was safe and effective for men was effective but not safe for women because it was staying in their systems too long, and they were going to, they were leaving for the morning, driving their car, and falling back to sleep. And also, even if you include women, even if you do better final stages testing with women, it leaves out all the possibilities that don't work as well for men but could work for women. And so this is where it's difficult because on the one hand, we want to say that overall our similarities vastly outweigh our differences, but also we do seem to have differences in how we respond to medications and how certain health issues present by gender and ethnicity. And we talk about this idea of assuming that particularly white male is normal and white female is deviant, and how that really creates problems all the way down. And she talks about problems with clinical trials in general. So it's difficult to do realistic research. It's extremely expensive and time consuming. There's always conflicts of interest. Even if you're an outside lab, you're being paid to do this research. And even if the drug company is even if they're trying to be very moral and ethical, there's still the risk that they will like you just a little bit less than they did before if you find data that doesn't really help them. And there's also very desperate populations. So there's people, I forget what I mean by that. I'm sorry. So I like this, again, this going back to the idea that feminism, advocating for people with less power, is helpful for everyone because it moves us toward more and more individualized medicine for everyone, because we know that not every body responds to medication in the same way. This next one, so I usually stick with US populations. I got suckered with this one, and that's just a silly way of saying I made an exception for this one for whatever reason. So thinking about how to talk about periods, and I think women's health in particular worldwide, there's a lot of ick factor that people aren't willing to engage with. So there's a lot of cultural restrictions, and part of why this one appealed to me is because I have more contact with South Asian culture because I married into a South Asian family. But it's not the only culture with restrictions. There are a lot of restrictions, and some of these can put women at risk for infections or for violence. So I remember when I was in middle school and I was with my dad for the weekend, and we were at my grandma's house. She grew up in rural Ohio, so kind of the outskirts of Appalachia, in the Depression. And so my period had started unexpectedly. I didn't have any pads with me, and I was having cramps. I was in a lot of pain. And so my grandma comes to me, and she very sincerely, she is imparting wisdom, and she says, sometimes I use a paper towel, or I used to use, because she had gone through menopause at that point. But sometimes I would use a paper towel. Like this was the most self-indulgent thing she could imagine. And like it's a little secret that I might not have thought of that she was passing on. And I think I was using a paper towel or something just as a kind of a stopgap measure until we could go pick up some pads. And I remember just like being horrified and saying like, no, Dad's going to take me into town to get some pads. And she was shocked and kind of disgusted that I was making my dad drive into town and buy disposable pads. So when we think about these taboos and these potentially harmful health practices, it's easy to think of many other cultures, but it also certainly exists or has recently existed in our own culture. Similarly, I was at a big gaming convention, PAX Unplugged, in Philadelphia, and someone that I was with needed a tampon. And it was very interesting to me how difficult it was for me to help this person find a tampon. I try to talk more openly when I talk about pads and tampons and menstrual cups and other things. I try not to be very secret, because when we treat things like secret dirty things, we continue to believe that they're secret dirty things. And one of the people I had met at the convention and was spending time with, she was like, oh, I think I might have something in my purse, but it was very much this secret, like, oh, let me give it to you, and let's, we're speaking in hushed voices that we're looking for a tampon. And I went to one or two different stores that one was a Wawa. It was a way stripped down Wawa, which was very disappointing. But I think it was a Wawa. But at any rate, I went and there was absolutely nothing there. And so I went somewhere else and did find eventually some tampons, but it was just very interesting that there was this air of secrecy and that it was hard to figure out where to get tampons, which is just such a typical thing. So again, just kind of an observation, not just of what's happening, but of the way it's happening and the content. The speaker talks about the materials being not objectionable in any way. So again, there's this pressure to be absolutely above reproach, which kind of speaks back to the idea where things like slut walks have to happen differently in cultures with more stigma and less power for women. And then she talks about the real effects on health. So you can get infections from using dirty products. Some areas have taboos against sleeping indoors. I don't remember if she talked about it here or not, but it's things I've read about in the past. And so there are cultures and places where women who are having a menstrual cycle cannot sleep indoors. Sometimes there'll be an outdoor shed or something where they can sleep. Sometimes they just have to sleep out in the open. And these are, I think there's some overlap with cultures where it's seen that if a man can access a woman and assault her, then it's not really his fault because he's a man, who could expect him to have any sort of respect or self-control. So there's a risk for sexual assault, which has very high consequences. Again, those are often cultures where once a woman has been sexually assaulted, for one, she's not really seen as a victim, and then also who wants to marry her now. But also there's risks of literally just being attacked by wild animals or being exposed to the elements. And then overall, just the issue of overall lack of information about one's body and what's happening, what menstruation is, what it's not. And you hear, I don't know if it's as often now, but if you go back even, 40, 50, 60 years or more, you hear women tell stories about they didn't know what was happening to them the first time and they thought they were dying. So thinking about how periods are treated in other cultures, but also thinking about how they're treated in the U.S. culture and what that says about women and women's well-being. The next video, I Don't Want Children, really emphasizes the medical autonomy and the paternalistic views of medicine often. So she tells a story that's really, instead of being a collaborative, like let's talk together, let's explore options, let's talk about the research and what tends to happen with women and try to figure out what's in your best interest. Instead, it really felt like a battle for control, and that the person, whatever doctor the person started with, really kind of resented her for being granted autonomy to have a procedure that she wanted. I think it's really important to separate your identity as a woman from your identity as a mother or a potential mother. So thinking about, not defining being a woman as being a mother or at least a potential mother. I think there's also a big focus on biological motherhood. I don't remember if she talked about this. I think she might have. But when we are so focused on fertility, I think it also forgets that families can form in a lot of different other ways too. It talks a lot about her efforts to convince her medical providers. For one, it seemed like it seemed like it was, a woman versus a lot of men making decisions about women's health. And I forget if, I think it was one of her physicians addressed her as little girl, but also her vulnerability here. And you can see she kind of regrets having, made nice so much along the way, but she really felt like she had to make nice to have access to the care that she wanted. I also can see how this is a tough issue, especially if you're in medicine and over the years you have seen people who regretted having sterilization procedures. I know of someone who in her 20s really wanted to be sterilized, and but just kind of accepted it as a thing that an unmarried woman of 28 with no kids couldn't be sterilized, and then later found a partner and became a mother of two. And so in her case, I would guess that she's probably pretty happy that she didn't get that procedure. So I think it's a really difficult topic. And at the same time, I know without a shadow of a doubt that this was not the way to handle it. I could see treating this with concern, making sure that there's a lot of information about options, talking about alternatives that are more short-term. But this was certainly not the way to do it. And I've heard many personal stories of similar types of experiences of being either denied sterilization or told that you need your spouse's permission. And I've heard, I don't know if I've ever heard of a man needing a spouse's permission to be sterilized. So it's not just let's rethink our system for sterilization in general. It's let's rethink the way women's sterilization is treated differently than men's sterilization. So what did I leave out? We talked, I had something about trans health. I don't think I had anything that specifically talked about sexual identity and health. So there's a lot of issues being left out. I also didn't get into trans issues during puberty. I think I might have talked about this before. That there's a lot of health decisions. So as far as physical development, secondary sex characteristics, there's a lot of hormones that happen during puberty. And so particularly if a person's parents are not supportive of their gender transition, or if, let's say, one parent is, but the other parent isn't, it can be really difficult to access hormones to stop, or at least, many of the hormones taken early on are to just kind of hit the pause button so that you can decide later. And if you stop taking those hormones, puberty will happen. It'll unfold in the usual way, just at a later date, is my understanding. And then there's other hormone therapies where you can take hormones to take on the secondary sex characteristics. So things like broad shoulders for men, broad hips for women, breast tissue for women, facial hair for men. These things are triggered by hormones, and so you can take things to just stop your hormones, or you can do treatment to start the hormones of the gender you identify as. And those are kind of two different steps with different considerations. Also, in general, LGBTQIA people experience a lot of discrimination and access issues with the health system. There's a lot of debate over whether medical providers are required to treat everyone. So if you're a counselor and a trans person walks in your office, are you obligated to treat them? And are you legally obligated? Are you ethically obligated? There's been a lot of discussion around this. And I think emergency situations are most critical because it could literally be life or death. But even long term, if you live in a more rural area and there's only a few psychologists in your area, and all of them want to refer you out to somewhere further away because they personally don't feel comfortable treating you, it can still create a real issue of access to care. Underrepresented groups, we talked some about particularly Black women. And again, we talked a little bit about trans women, but there's still a lot of specialty issues that I'm leaving out. And global perspective, again, I let a little bit more sneak in than usual this week, but it's still very heavily focused on the US. All right, thanks.